So a quick review of echo. The orientation for the subcostal view of the heart is with the dot towards the patient's right-hand side, holding the probe underneath the xiphoid process up towards the left shoulder, showing an image like this, with the left lobe of the liver, the right ventricle, the left ventricle, and the corresponding atria. The most useful evaluation of the heart comes from the parasternal long axis view, where the dot is now again towards the patient's left hip, giving an image of the right ventricle in front, the left ventricle, the aortic outflow tract, and the mitral valve. Of the heart using the parasternal short axis view is also very useful. To obtain this view, you move from the parasternal long axis view, which we already reviewed, to the parasternal short axis, which gives you a sense of LV function. On this view, you can see the walls of the left ventricle with their concentric squeeze. You can see the papillary muscles here. And if you aim up a little bit, you can appreciate the mitral valve, which looks like a fish mouth. Papillary muscles and fish mouth of the mitral valve. The parasternal short axis view, which is obtained from moving from the parasternal long axis view, which we just saw, 90 degrees, now towards the patient's right hip. What this does is it gives you an evaluation of the left ventricle circumferentially, giving you a sense of the squeeze of the heart. What you can see here is the left ventricle, the papillary muscles. You can see the circumferential squeeze of the left ventricle. Moving up, you can have an evaluation of the mitral valve. Aiming up a little bit more. Is the four-chamber apical view, which is obtained by placing your hand over the patient's heart and feeling where the point of maximum impulse is. The probe is then placed in that location and adjusted so as to maximize the visualization of the four chambers on the screen. In this orientation, the left ventricle and atria are here. You can see the descending aorta on this side, which can help you determine left versus right in this orientation. And the right ventricle and right atria are on the left side of the screen. This is the most challenging of the images to obtain, but can be of significant use when trying to assess the size of the right ventricle. For example, in a case of a physiologically significant pulmonary embolism, where the right ventricle can be larger than the left ventricle. Please note, however, that a small pulmonary embolism cannot be ruled out using this method. You can see in this picture that the right ventricle is smaller than the left ventricle, and the wall of the septum bows out into the right ventricle, which is expected given the higher pressures of the left ventricle. In the case of, for example, a saddle embolism or other causes of pulmonary hypertension, the right ventricle can grow to be larger or as large as the left ventricle, and the septum can bow out into the chamber of the left ventricle.